Good morning, everyone, and welcome back to Clinical Horizon. I am Dr. Mohan Gayen, and today we will discuss one of the most important global updates in hepatology, the global consensus recommendations for metabolic dysfunction associated steatotic liver disease and steatohepatitis. This is not just a change in terminology, it's a complete shift in how we understand, diagnose, and manage fatty liver disease in the context of metabolic health. Let's explore what this global consensus really means for clinical practice and patient care. Until recently, we used the term NAFLD or non-alcoholic fatty liver disease. It defined the condition by what it excluded, focusing on the absence of alcohol use rather than the actual underlying cause of the disease. But as science advanced, our understanding expanded. We now know that the true driver is not just fat accumulation, it's metabolic dysfunction. And that's what led to the emergence of a more accurate and inclusive term, MASLD or Metabolic Dysfunction Associated Steatotic Liver Disease. MASLD recognizes the metabolic roots, connects the condition with diabetes, obesity, and cardiovascular risk, and provides the clarity that NAFLD lacked. This is not just a change in name, it's a redefinition of the disease itself. MASLD is not a single disease, it's a continuum. On one end, we have simple steatosis, excess fat quietly accumulating in the liver, but as inflammation and cell injury progresses, we cross into MASH or MASH, where hepatocellular ballooning and fibrosis begin. Behind the scenes, the key culprits are insulin resistance, lipotoxicity, and low grade inflammation fueled by the gut liver adipose axis. The liver becomes a mirror of the body's metabolic chaos, and that's why MASLD is not just a liver disorder, it's a metabolic ecosystem under stress. Over the years, multiple societies proposed different terminologies NAFLD, MAFLD, NASH, each with slight differences. This led to confusion among clinicians, researchers, and even patients. What the world needed was a single unified voice, a globally accepted framework that would streamline research, policy, and clinical care. This consensus bridges that gap. It brings together experts across continents to speak on common language for a disease that knows no borders. So, what are the goals of this landmark effort? To develop globally harmonized, evidence based recommendations for disease definition and terminology, screening and risk stratification, diagnostic algorithms, management and prevention strategies. In essence, the goal was to bring consistency where there was fragmentation and clarity where there was confusion. It's about giving clinicians everywhere a common, reliable roadmap. This consensus was not a casual expert discussion, it was a systematic, structured, and evidence driven process. Experts from hepatology, endocrinology, cardiology, and public health came together to cover the entire disease journey from epidemiology to diagnostics and from prevention to therapy. It's comprehensive, collaborative, and made to shape the future of liver care. The authors followed a 12-step process, a scientific choreography where each step refined and validated the next. From comprehensive literature reviews to global consensus meetings, from expert insights to multiple rounds of refinement, every detail in this guideline was thoughtfully considered and validated. This process ensured that recommendations are not just expert opinions. They reflected a true global consensus built on robust data and collective expertise. Now, this is remarkable. They used the Delphi method, a recognized gold standard for building expert consensus. Here's how it works. A panel of experts independently answers structured questionnaires. Their responses are compiled, anonymized, and shared back for the next round. Round after round, opinions converge, bias free, pressure free. In essence, it's a collective, thoughtful process where differing views evolve into consensus. This is how the global MASLD recommendations achieved both precision and neutrality. The scope of this consensus was broad, covering every critical domain. Definition and classification, epidemiology and burden, screening and diagnosis, risk stratification, therapeutic and preventive strategies. By addressing each of these systematically, the guideline gives clinicians a 360-degree view from identifying who's at risk to how to manage and monitor them effectively. This was not a Western consensus, it was a global collaboration. Experts represented every major region: North America, Europe, Asia, Africa, Latin America, and Oceania. The participants included hepatologists, endocrinologists, cardiologists, radiologists, and epidemiologists, a multidisciplinary alliance. This diversity ensures that the recommendations are universally adaptable, whether in a tertiary care center or a community clinic anywhere in the world. The statistics are striking. Nearly 1 in 3 adults worldwide has steatotic liver disease. That's about 2 billion people. Among them, up to 25 to 30% may progress to MASH, the inflammatory stage that drives fibrosis, cirrhosis, and cancer. And it does not stop here. We are now seeing pediatric MASLD as childhood obesity and insulin resistance rise globally. Beyond the liver, MASLD doubles the risk of cardiovascular diseases, making heart attacks and strokes the leading cause of death in these patients. This is not just a hepatology issue, it's a public health emergency. MASLD is silently straining healthcare systems worldwide. Hospitalizations, complications, and long term care costs continue to rise sharply. In many countries, MASLD is now one of the top 3 indications for liver transplantation. But the real cost is not just economic, it's emotional. Imagine a young diabetic mother unaware that her liver is slowly failing, or a middle aged man who survives a heart attack only to discover advanced fibrosis. This is the silent epidemic of our time and it demands urgent attention. Early detection is our best weapon. The consensus recommends focusing screening efforts on high risk groups with type 2 diabetes, obesity or metabolic syndrome, dyslipidemia, hypertension, family history of liver disease. Because catching MASLD early can change the story from irreversible damage to timely intervention and recovery. Alcohol remains an important variable in disease classification. The consensus recommends careful alcohol assessment because even modest consumption can influence liver outcomes in MASLD. The updated framework recognizes that liver disease rarely has a single cause. It acknowledges that metabolic dysfunction and alcohol use often coexist, not compete. So instead of excluding one to define the other, we now integrate them. A more realistic and patient-centered approach to liver health. MASLD rarely occurs in isolation. It's closely linked with several metabolic conditions like type 2 diabetes, obesity, dyslipidemia, hypertension, and cardiovascular disease. Each of these adds a layer of risk, accelerating liver injury and raising mortality. So, managing MASLD is not about the liver alone, it's about the whole person, their diet, their heart, their hormones, their habits. It's time to stop treating the liver in isolation and start treating the metabolic human being. Not every patient with fatty liver carries the same risk. Some remain stable for decades, while others quietly progress to cirrhosis or liver cancer. That's why risk stratification is essential. The consensus recommends a stepwise approach combining simple, accessible tools with more advanced non-invasive tests. What is the goal? Identify patients who need closer evaluation and spare low-risk individuals from unnecessary anxiety and testing. In short, it's about being precise and patient-centered. Everything begins with the FIB4 score, a simple, inexpensive calculation using just age, AST, ALT, and platelet count. Now, how to interpret? If FIB4 score is less than 1.3, that means low risk of advanced fibrosis. If FIB4 score is more than or equal to 1.3, that means possible risk. Move to next step. It's easy, reproducible and cost effective. Perfect for primary care screening. Think of it as your first gatekeeper, helping decide who needs further evaluation. For patients with elevated FIB4, the next step is vibration controlled transient elastography or VCTE, commonly known as fibroscan. It measures liver stiffness or LSM, a direct non-invasive indicator of fibrosis. If LSM score is less than 8, that means low risk, can be followed in primary care. If LSM is more than or equal to 8, that means higher risk, needs hepatology referral and or additional NITs. This two-step model FIB4 followed by VCTE provides a powerful screening algorithm with minimal burden on healthcare systems. When VCT is not available or results are inconclusive, other non-invasive tests can complement the assessment. These include ELF or Enhanced Liver Fibrosis Test, Serum Biomarker Panel, FAST score combines fibroscan and AST, MAST or MRI AST score integrates MRI findings with AST. Each adds a layer of diagnostic confidence. The consensus emphasizes flexibility. Use horse accessible but always follow a structured evidence-based pathway. Here's the algorithm in action. In the step 1, screen for MASLD. In the step 2, calculate FIB4. If it is less than 1.3, that means low risk, manage in primary care. If it is more than or equal to 1.3, proceed to VCTE. In the step 3, interpret VCTE. If LSM less than 8, that means low risk, and if it is more than or equal to 8, refer to specialist and or further NITs. This simple 3-step pathway transforms complex decision making into clear, actionable guidance, ideal for real world practice. No matter how advanced our tests get, the cornerstone of MASLD management remains lifestyle modification because the best medicine is still movement, mindfulness, and moderation. The three pillars are weight loss, healthy diet, physical activity, and behavior change. Science proves that even modest improvements in these areas can reverse steatosis, reduce inflammation, and even regress fibrosis. We are not just treating the liver, we are helping patients reclaim control over their health and future. Let's talk the numbers. Weight loss targets. If more than or equal to 5% improves steatosis. If it is between 7 to 10% improves inflammation and ballooning. If it is more than or equal to 10% may even reverse fibrosis. That's powerful. Every kilogram lost is not just a number, it's a message of recovery to the liver. We should communicate this hope to our patients. Small changes matter, consistency heals. Diet therapy is not about deprivation, it's about transformation. The consensus favors Mediterranean style diets rich in fruits, vegetables, whole grains, nuts, and olive oil. Reduce intake of fructose, refined carbs, and saturated fats. Limit sugary beverages and processed foods. Interestingly, coffee without sugar may offer mild hepatoprotective benefits. The best diet ultimately is the one the patient can sustain with joy and discipline. Physical activity is a medicine with no prescription cost. 150 minutes of moderate exercise per week, brisk walking, cycling, swimming, etc., can significantly reduce liver fat. Resistance training builds muscle, improves insulin sensitivity, and supports weight maintenance. Beyond exercise, behavioral support, goal setting, self monitoring, counseling helps maintain motivation because lasting change is born not in the gym but in the mindset. When lifestyle alone is not enough, and for many it is not, pharmacologic therapy steps in. The consensus classifies medications into anti-diabetic agents with proven liver benefits, novel and targeted agents for MASs, supportive therapies addressing comorbidities. The key principle: treat the metabolic roots, not just the hepatic branches. Among anti-diabetic drugs, several have shown promise in MASLD. GLP-1 receptor agonist like semaglutide, liraglutide reduce weight, improve steatosis and inflammation. SGLT2 inhibitors lower hepatic fat and enhance insulin sensitivity. Pioglitazone improves histology in biopsy proven MSAs, especially in diabetics. These agents do more than control glucose. They reprogram metabolic health, helping both liver and heart thrive together. Other drugs under study include vitamin E, may benefit non-diabetic MASH patients, though long-term safety must be weighed. FXR agonist, PPAR agonist, and FGF21 analogs represent next generation options currently in clinical trials. The landscape is evolving fast and the future looks bright for targeted mechanism based therapies. Now, Resmetirom, first approved MASH therapy. This is historic. Resmetirom, a thyroid hormone receptor beta agonist or THR beta agonist, is the first FDA approved therapy for MASH with fibrosis. It works by enhancing hepatic fat metabolism and reducing inflammation and fibrosis markers. Finally, we have a therapy that does not just promise but proves histologic improvement in MASH. This is a turning point in hepatology. Resmetirom should be considered in patients with biopsy confirmed MASH and significant fibrosis more than or equal to F2. It requires monitoring of thyroid function, lipid profile, and liver enzymes. The consensus encourages its use in conjunction with, not instead of, lifestyle measures because medications can heal the liver but lifestyle heals the person. As with all chronic diseases, prevention and surveillance remain the pillars of long-term care. Key focuses include hepatocellular carcinoma surveillance in high-risk individuals, monitoring disease progression via NITs or imaging, vaccinations and preventive care, especially for hepatitis A and B, addressing cardiovascular risk factors because the heart often fails before the liver does. Our ultimate goal is not just to manage MASLD but to build a future free from its burden. Hepatocellular carcinoma or HCC is one of the most feared complications of MASLD. The consensus emphasizes targeted surveillance for high-risk groups, patients with cirrhosis regardless of cause, those with advanced fibrosis or F3, F4 stage even without cirrhosis, and selected high-risk patients with metabolic comorbidities. Now, what is the modality? Ultrasound every 6 months with or without alpha fetoprotein or AFP measurement. Early detection changes destiny because when caught early, HCC or hepatocellular carcinoma can be curable, not catastrophic. MASLD is dynamic. It can progress, stabilize, or even regress. That's why ongoing monitoring is crucial. The consensus suggests repeating non-invasive tests like FIB4 or VCTE every 1 to 3 years, depending on baseline risk. For those at higher risk or with comorbidities, monitoring should be more frequent. Remember, what you don't monitor, you cannot modify. Progression can be silent, but if we listen carefully, the test whisper the warning long before the damage shouts. Key recommendations include vaccination against hepatitis A and B, regular cardiovascular assessment, cancer screening as per age and risk, sleep, stress, and mental health support. These may seem simple, but they add up because health is not just about surviving disease, it's about living well. Pregnancy introduces a unique physiological stress, and MASLD can complicate it further. Women with MASLD face higher risk of gestational diabetes, preeclampsia, preterm delivery. Hence, the consensus calls for early identification and multidisciplinary care involving hepatologists, obstetricians, and endocrinologists. Pregnancy is a time of creation, not complication. By recognizing MASLD early, we protect two lives with one intervention. The face of MASLD is getting younger. Childhood obesity and sedentary lifestyles are fueling an alarming rise in pediatric MASLD. The consensus stresses early lifestyle intervention as the primary therapy because the same habits that harm adults now begin in childhood. Imagine a 12-year-old with fatty liver and insulin resistance. This is not tomorrow's problem, it's today's warning. Addressing pediatric MASLD is not just medical, it's moral responsibility. So, how does this global consensus differ from earlier ones? Earlier guidelines like ASLD or EASL varied in terminology, thresholds, and risk definitions. This document unifies them, introducing MASLD, MASA's terminology, structured risk stratification, and a standardized diagnostic pathway applicable worldwide. It bridges the divide between hepatology, endocrinology, and primary care. Finally, on map, on language, on mission. What makes this document powerful? Let's highlight its key strength. Global collaboration. Experts from every continent contributed. Data driven recommendations, not opinions but evidence. Practical algorithms, easy to apply in both primary and specialist settings. Inclusivity, covers adults, children, pregnancy, and comorbidities. Clarity and consistency, a single unified terminology for global practice. In short, it's a living roadmap built for real world use. No consensus is perfect, and this one humbly acknowledges its limitations. Many recommendations are based on expert opinion, where evidence is still emerging. Long term validation in diverse populations is still needed. Access to non invasive tools like VCTE or ELF remains limited in low resource settings, but these are not flaws, they are frontiers. Let's sum it all up. MASLD replaces NAFLD, highlighting metabolic dysfunction as the root cause. Risk stratification is stepwise: FIV4, then VCT, then advanced NITs. Lifestyle remains the foundation of therapy. Pharmacologic options led by Resmetirom are evolving rapidly. Surveillance, prevention, and multidisciplinary care are essential. Above all, MASLD is not just a liver condition, it's a reflection of metabolic health. Healing begins when we treat both the liver and the life. I hope this session helped you not only understand the global MASLD consensus but also feel inspired to apply it to make liver care more holistic, inclusive, and human. If you found this valuable, please like, share, and subscribe to Clinical Horizon for more in-depth evidence-based discussions in internal medicine. Stay curious, stay compassionate, and as always, keep learning because every patient deserves your best. Thank you all.